Good morning, everybody. My name is Matt Noonan. I'm part of I'm now part of the Girth elective team, formerly known as Elective Care Improvement Support Team, and I'm one of the people involved in setting up this program, although in a much more minor way than my colleague Robin and Alison, who's not here today. So I'm going to sort of facilitate and take us through today's session, which is around the sort of inter-provider communication and the processes that work around those things. So when we set this program up, we got a lot of requests and discussions with organisations that have said that this part of how their NDTs work is a real challenge, which is sort of understandable, given that the NDT process has been around for a long time, and then a lot of cases are sort of tertiary relationships have formed after that, and so the processes and how you might set them up if you started from scratch now, obviously not what people are able to do. However, interestingly, when we've tried to find organisations that have tackled this problem and really, put the bit between their teeth with it, we've really struggled. And so we're hoping today is a sort of starting point for some of you on the call who this is an area of concern for you to get some ideas and to get some support and some thought and have the ability to discuss some of these issues, so that next year or next time I run these, you guys are coming back to present and saying this is the kind of stuff we do. And some of it could be quite big, but I think a lot of this can be quite small. And I think actually when we have spoken with other organisations since we started this process, you often find that people have actually done stuff. They just didn't sort of necessarily badge it as like, right, we're actively going to improve this. They just, did stuff that has made things better. So this session is different from all the others where we've had presented in others, and we're not doing that today. So today is a session where we're going to do a bit more group discussion, more thinking around how we resolve what these challenges may be and for yourselves, and then using the sort of group mind to think through some of these things. How can we overcome them, and then importantly, what would the actions be to deliver that? So how do you sort of take a good idea and move it into operational practice? So we're gonna Christo, just move, or Robin, just moving on to the next slide. I think there's a bit of housekeeping we've got to get through. So standard stuff as usual. When we're talking to each other, can you have your cameras on? So we are going to break out into breakout groups. I don't mind now if you want to have your cameras off, but when we break out into breakout groups, please have them on so we're talking, listening to people. Use, again, while we've got the big session, please keep yourself on mute, but obviously when you're in smaller groups, obviously feel free to talk. Please do participate, contribute ideas. It may be that you're part of an NDT that doesn't have a massive problem in this area, but your ideas about and your thoughts and potentially how you do things currently may well be really useful for people. So do actively participate. As always, use the chat box if you've got questions. Again, more than happy for people to put their hand up and interrupt us. But if you want to put stuff in the chat, please feel free to. And similarly, listen to people when you're in the groups and when we're feeding back. Actively listen. Please don't try and do emails, etc. while you're on the session. I think we probably will be able to give people a bit of time back today. We'll see how we get on. So there will probably be some time at the end of the day for you to catch up on some of those tasks. As always, stay open-minded. Be receptive to these sort of different perspectives. What works for some people doesn't work for others, but please do have that sort of open-minded view. So if we move on to the next slide. So we're going to just do a few minutes using a thing called Mentimeter, which hopefully some of you or all of you have used before, but if not, you either need a little mobile phone, or you can do it on your desktop. We'll put a link into the chat in a second. Essentially, when we go on, there'll be a sort of code that you go to a website, you put a code in, and that will link you up into a way of sort of typing in um, your views about things. So we're going to talk about some of the challenges around inter-MDT working, and obviously that can be from your perspective, you're part of a network where you're referring in or receiving referrals from. But if you're not, the principles are very similar in terms of how you refer people between entities within a provider. So, don't feel like your views aren't valid or aren't useful, because they absolutely are. Because all of this is largely down to relationships and process. So, you know, the stuff that people have done within providers are often very applicable to stuff that happens outside. It's just sometimes a bit easier to do when you're in the same organisation. So, Crystal, I think you're going to bring up oh, there we go. Look at that. So, either on, oh, so yeah, as I say, either on your phone, do you want to use the QR code, which there we go, perfect, thanks, Crystal. Or if you go to menti.com and type in that 8-digit code, sorry, then that will bring you to this little sort of slide deck that we're going to go through now. So let's give people a couple of minutes. Please do this. I can see there we've got 26 people on the call, though some of them are facilitators, so I'm expecting at least 20 responses on every one of these questions. So got some people joining already. Excellent. Right. See if I can put a link in the chat as well while we're doing this. I'll put a link in the chat as well. I just want to think if you find it difficult, click on that. So that looks like we've got 30 people in the room, which is great, given we only got 26 people on the call. So, right. So, Crystal, should we move on to the next slide? Hopefully that's going to be up.
Yeah.
5, 6, 7. So the first question we've got is how does the relationship work currently in your MDT? Like, what are your thoughts on it? What are your feelings? Is it good, bad? Things that you think you can put. I think you can put in as many answers as you want. So, and they should. Oh, there we go. Look at that appear like magic. Oh, so we've got some good practice while this thing's coming up. That's good to see. That will, I'm sure, be very useful. Yeah, some challenges, collaborative. That's really good to see. Busy, yeah. Right. Okay, that's good. Variable. Okay, precision. That's good to see. Okay. Fantastic. Yeah, letters take a while. I'm sure is patient-centered. That's really powerful, really positive. I think it's a really valuable comment there, because I think, you know, if that's the focus for everybody involved in these sort of quite, yeah, let's be honest, like, yeah, the MDT, as we know, is become a more and more difficult thing to run and keep effective. And yeah, when you're an NDT chair or you're part of an NDT, being sort of dealing with these pressures is difficult just within your own organisation, so let alone trying to help solve things that affect other people from outside the organisation. So having that sort of patient-centered view and approach, I think, can sometimes break down some of these barriers. Variable. Okay, great. Up and down, yeah. So that's good. So, well, I'd say the last time we ran this, we had a lot less positive comments. So that's really great that people have got a lot of things in here that affected good. So hopefully, as we go through the discussion, people may well have examples from their own entity that they can describe around how they do things that are helpful and sort of overcome some of the challenges around this. So if we move on to the next question. So I like in this bit, I like people to look about what the biggest challenges are around this. So this can be from your own personal experience, but potentially from just your knowledge of the things, and then we'll see what comes up. So technology number one. Yeah, I think interoperability and people using different systems is always always a challenge. Communication, streamline IT issues. Yeah, having good written guidance. Uh, okay. Clear out, yeah, it's the outcome process, referral process not working, but lack of communication, abbreviation. Yeah, that's really interesting. Yeah, I mean, we have that when we do a lot of work with sort of grad schemes and people quite new to the NHS, and it is amazing how quick we are to get into obligations without even realizing it. Job planning, the time available, time until listed for discussion. Yeah, I mean, we heard just the sort of organisation of the listings can be problematic in terms of like, is everything discussion more one organisation time, unclear to take actions, complexity and time, patient voice. Interesting. So I wonder if that's um, around ensuring that the patient's voice is being heard when it's being discussed at an entity away from the sort of maybe the CNS team. Okay, time again. Um, sort of, look at this, fancy. So outcomes, technology, guidance, timings. Um, okay, brilliant. Thank you for that. I just scroll see the prep time. Yeah, so how we're prepping and ensuring all the information available for discussion. Yeah, so like that sort of communication in terms of making sure patients are prepped and you've got everything you need, and being clear what those things are so the discussion is fruitful. Yeah, it's hard enough within an organisation, let alone across boundaries. So yeah, that's very helpful. Um, okay, fab. Thank you. Looks like we've reached the end of responses. There seems to be a decent number, so well done, everybody. Thank you for participating. Um, so we're gonna sort of Robin in the background is beavering away, grouping those things. So I think we're the next day I'm going to hand over to Robin. Who's going to take us through the crux of where we're going to go next. But we're going to try and sort of break out some of those challenges into. Oh, there you go, as if by magic. So to talk through how we're going to about the challenges around these things, and then hopefully what people either have done or thoughts and ideas that people have around how you might solve some of those challenges. So we're going to break into, well, I'll let Robin take us through. So Robin, I'll hand over to you and see
Thanks,
some
Matt.
of you.
So yeah, I have grouped your feedback into themes. I hope those things are right. If anyone thinks that anything is missing or that there's something that we really do need to consider as a theme, please do let us know. Pop your hand up and put it in the chat. But this is how I have grouped them into themes. So a lot of people mentioned referrals. So how can we ensure all necessary information is available? I think not only available, but also accurate. So how are we assured the information is right? Feedback, so taking that theme of communication. So how can the process of communication of MDT outcomes in particular be improved? Time, so everyone's short of time, everything is rushed. So how can meeting efficiency be improved so that all patients are discussed within time? I think that's possibly specific to specialist MDTs, but could also apply to local MDTs if you're then feeding into a specialist MDT and referring patients on. And also technology obviously came up. So how can the use of technology improve into MDT processes? I think Anna's just pointed out the patient voice is the one that is missing. You're absolutely right. I think that fits into referrals. So actually, when we're talking about necessary information, patient voice is a part of that. And, patient choices and decision making with them. So I would group that into referrals. So as part of that necessary information, is patient voice included? Is it available? Has that conversation happened with them? So what we're going to do, I'm going to ask if somebody could just pop those themes in the chat for me so that everyone can see them. As Matt mentioned, we're going to do some more breakout session work today. We're going to break into groups. So it will be a group per theme. So each group will have around 20 minutes to discuss that theme. So please discuss your personal experiences of technology, communication, referrals, etc. into provider MDT processes. So please discuss what you find challenging, or on the flip side, what you find really positive and what really works in your MDT. And consider the question and the potential solutions to that question. So, how can we answer that question? And also, what are the actions needed to deliver the solution to that question? And also, if there are any obvious barriers, if there are, how can these be overcome? And as usual, try to think outside the box, especially if something hasn't quite worked before. So, if you've tried to change referral processes between your MDTs, it hasn't quite worked, discuss why. Share that with each other. Please make suggestions for other people, and also make a note of your actions. We will ask afterwards that everyone come back and share their conversations and just summarize what they've discussed, their solutions, their actions. And each group will have around 5 minutes to discuss those. And we'd like to pick on one person from each room to share that with us. So please, when you go into your room, just decide who is going to do that verbal feedback when we come back into the room. So I'd ask everyone, when you get moved into your breakout rooms, could you please have a look at what number room you're in? So if you look in the top left-hand corner of your screen, it should say room 1, 2, 3, or 4. That will be the theme you're discussing. So as you can see, the themes are numbered. So that will be the theme you're discussing. Also, obviously, we're giving everyone 20 minutes. Everyone might be quite quick to discuss their theme. If you do finish, your conversation around one theme, please pick another and discuss that. So if you're discussing technology, you've finished your discussion, everyone's shared, you've come up with solutions and actions, move on to referrals, or one of the other themes. That's absolutely fine to discuss more than one. We don't want to limit these conversations. There will be a facilitator in each room, so they will just be on hand to help with the conversation if needed. So it will just be a person from NHS England who's just there to help you have that conversation, nothing more. So if you do have any questions or any problems, have a chat with them.
Thanks,
Okay,
Robin.
I think we're ready now.
It's like Crystal, there's a couple of people have put some preferences. I don't know if you're able to accommodate those.
Yeah, thanks.
I'm going to say no more preferences because otherwise Crystal will spend the next 10 minutes moving people around rooms. But if people go into a room and there's another thing they really feel they want to talk about, I'm sure the facilitators can create some space for that group to talk about it as well. So, right, Crystal, are we ready to send this off into the ether?
Yeah, we're
Okay,
ready.
great.
Thanks, Matt. Like Robin said, each room has a facilitator. It has been automatically done, so not all preferences will be met, but like Matt said, there will be opportunity hopefully in each room to discuss if you're really passionate about a particular topic. So we'll open the rooms now. You'll get a reminder when there's 5 minutes and 2 minutes left, and you'll be brought back automatically. So we'll see you on the other side.
Hopefully you all had the opportunity to kind of volunteer or nominate somebody to give some verbal feedback on your discussions, because we're going to go round now and just invite people to share that. In terms of feedback, if you could just, summarize what your conversations were about, if you identified any solutions, if you identified any particular barriers to those solutions, and if you identified any actions to possibly implement some of those solutions. So I'm going to go to room 1. We'll start with. Who is speaking on behalf of room 1? Anne, yeah, come on in.
Hi. So our discussion was regarding the referral process, and we initially had a issues that we have with our current processes. There were some definite common themes there regarding, lack of maybe clinical oversight in the referral process for the bulk of the referrals going in to the MDTs, and that a couple of MDTs that were represented in our group don't actually have a consistent referral performer process, or perhaps there's variation across trusts. So one trust had 2 MDTs due to a recent merger, and I know from our own trust that can be problematic, and sometimes those arrangements last for decades, I want to say. And we then kind of moved on to having a discussion regarding kind of best practice where that existed and what was happening. So kind of to focus more on kind of solutions, we agreed that there needs to be a referral process that's clear and is clinically led and not reliant on a non-clinical team member. Safety netting needs to be part of the process to ensure that there are no delays. So that's where you don't throw the baby out with the bathwater and not have any input from your coordinators to say, oh, I've had histology on this one, but they're not on the list. A performer were used to consistently ensure minimum information is available to the MDT, including the question to the MDT, what is the team who are referring looking for, and also to include the patient preference on that form so that their voice is heard. The CNS that we had in our team felt very much that the clinical staff, particularly the CNSs, if that patient voice is to be heard, need ring-fence time to prep for the MDT. The use of technology could perhaps overcome some of the problems, so that actually you're not having to write the patient's name, the number, the whatever, that actually the technology would draw that all in, and then the clinical time would be spent on actually giving the clinical information. And I think there's a system called Patient Pass that's used by one of the trusts in our region. And also one thing that came up towards at the beginning and at the end was assessment of straight to test patients, so that sometimes patients are being discussed in MDT and actually none of the clinical team members in the MDT have actually seen the patient. So that can be problematic because one, the patient voice is potentially missing, but also no idea about the patient's function and state, Okay, so that's all from us.
Thank you so much. Sounds like you had a really comprehensive discussion, which is fantastic.
Thanks, Anne. You summarised way better than I could have done. Thank you.
Really good job, Anne. Yeah, I mean, you mentioned patient paths. I learned of patient paths the other day, actually speaking to an MDT lead from your region, and just to let people know if they're not aware of it, it's an online system where you can electronically refer patients between trusts. So I think it's I think it might be in a web browser, but somebody will correct me if I'm wrong if I've got that incorrect. So that you don't have to worry about interoperability of systems between MDTs because you can do it via patient paths. And doing it electronically means you can set some fields mandatory. So if you need information in a particular field, you can make it mandatory so that the referrer won't send unless that information is included. And we can share a link if anyone's interested in exploring that. I believe it does cost money, which is obviously might be a bit of a barrier, but it is something to explore if anyone's interested. Richard.
Yeah, hi. As skin cancer lead for our trust, I've used it recently. So we're in Durham, and the regional hepatobiliary service is up in Newcastle, the Freeman Hospital. And we started using it and interacting. And it's actually, the way they've set it up is really quite good. Because what it does is the referring clinician gets the kind of email prompts that things are changing within this kind of, it's almost like a live forum where the patient is being discussed and any changes made on their side. So for example, it was, thank you for the referral, Mr. Chalmers. We will discuss this case on Tuesday. And basically, so you do the pro forma through that system, and then the team, the consultant lead, basically changed something on there to say, discuss today, this is the outcome, we need further scanning. And then I get prompted through an email prompt to go back in, and then I see what's happening with my patient. And actually, even during that, we were kind of going, oh, would you like me to organise the scan because it's local? I mean, yes, please, please upload when it's done. So it's kind of very interactive, and actually it captures that patient process, which I've always been worried about when you just hand a patient over from one MDT to another. And it's that kind of the issue of, I just mentioned it in my group, sometimes you get, dear MDT, can you manage this patient? Many thanks, lung MDT. And you're like, there's no person attached to it. And that becomes a real issue then. Who can you contact to say, how's this patient getting on? But this kind of system that kind of goes backwards and forwards into your NHSnet inbox and online is actually quite good. So I've quite enjoyed using it for, I think, 2 patients now under my care. So it's got a good trail, and kind of allows us to be really up to date with things happening almost in real time. So yeah.
Thank you so much, Richard. That was really helpful, and really good to know from practical experience that it's a system that works and can help with that communication. Thank you. I'm just wondering, as a follow-up, room 1, did you discuss any kind of mitigations or processes for what could happen if you don't receive the referral information you need for MDT?
No, I don't think we did.
Okay, that's fine.
There
wondering.
was some discussion about when you're completing the form. So some resistance about completing the form is that it could prolong the patient pathway, but that was about it, I think.
Okay, great. Thank you ever so much for sharing. Okay, we're going to move on to room 2. Who is speaking on behalf of room 2?
Hi, it's Victoria. Calling
Hi.
from room 2. So this conversation was around barriers, I think, solutions and thinking outside the box in terms of MDT outcomes. So we discussed the issues around communication. So I'm just going to whiz through the list, and then we'll talk about some of the solutions that came out the back of that. if that's okay. So unclear MDT outcomes from tertiary centres. So when we say that, it's more about who is responsible for what needs to be done, what does need to be done, and when does it need to be done by. Tertiary centres taking over patient care when not required. So again, this could be patient's been referred, obviously, on a cancer pathway, but they pick up something else. That something else could be done in our centre on the Isle of Man, but they picked up the care. So in terms of best possible patient outcome, the patient is then under their care, but having to travel back and forth from the Isle of Man, which isn't necessarily the best thing when we could be seeing them for that part of treatment. Tertiary centres, so we send our referral packs off, and within the referral pack we always make it really clear that any correspondence outside of the direct MDT outcome is to come back to the referring clinician. What we're finding with all centres, it's not particularly one, is that they send the letters back to the clinic, to the GPs, not back to our hospital. So then we're having to go back as MDT coordinating team to try and get the patient update letters sent back to us. In terms of MDT outcomes abbreviation, so in some instances we're unable to understand who is responsible for the action because of the abbreviations. We're not sure what the action is or who that person would be. We see this a lot in terms of outcomes, so data protection breaches. So as our organisation, when we send patient information out, we have to password protect everything that we send, but then our patient outcomes are coming amongst a load of other outcomes. So we're seeing patient information that we shouldn't be seeing. Our outcomes are being shared with people that should be seeing our patient information either. We have different systems between different centres, so it doesn't always talk to each other. We have different outcomes, so some trusts outcome via SCR, other trusts outcome differently, so it's not always consistent what comes back. Feedback provided but no changes made. So we've had quite a few instances whereby we've had feedback saying for MRI scan for this for outpatient appointment. So we then have to go back and say, well, who's going to do that MRI scan? When do you need it done? What sort of part of the body do you need scanning, etc. So then we're having to go back and forth for information because again, it's not clear what, how much and by when needs to be done. But that feedback we just get, oh, well, it is what it is. You know, there's no sort of further development or discussion point of how we could support improving that process. So moving on to solutions and outcomes, I think it's around the sort of clarity. So when we're outcoming, I know from an Isle of Man perspective, we're very clear, I guess, we'll work together of what, how much and by when. So it could be if patients for an outpatient appointment, we know exactly who and when that appointment's going to be with. We talked about best practice and how we could feedback to sort of get the attention of the trusts, and we thought maybe we could feedback through a Cancer Alliance and talk about how we standardise referrals or outcome performers across all of the trusts, so we're all on the same page and it's being generated from the Alliance rather than just particular individual centres. And then communications to come back again to clinicians, not to GPs. I'm not sure what the solution is for that, other than we keep writing and we keep asking for it. And then it's password protecting, either password protect the outcome lists that come back or remove patients from the trusts, the lists that come back. But appreciate, you know, there's a lot of patients that go through for discussions as well. Another thing that we also discussed is a rejecting referral policy as well. One of the teams actually does reject referrals coming through in their policy for that too. So I don't know whether there's something we can flip on the outcome side for that as well, in terms of how we could challenge some of the outcomes that come back as well, but obviously in a positive, professional way rather than just a quick pushback. I think of guidance, we could do with some guidelines for referrals and outcomes as well, if there was a standard set of guidance, but again, could that come from an alliance or somewhere else where these things are standardised? I think that's everything we covered.
Thank you so much, Victoria. Again, it sounds like another very thorough, comprehensive conversation. I'm just wondering if anyone else has any thoughts on solutions to ensuring MDT outcomes are communicated timely and accurately from any other group before we move on? Yeah, Natasha.
Sorry, I was in that group, but I wanted to pick up as well that which Victoria touched on. So Laura King's College also talked about that they've arranged a network event, I think in the new year, and I think bringing people together and understanding both sides and outcomes being picked up on there. I think that's why Victoria also picked up on the fact that where there's challenges to that, then using the local cancer alliances to help, guide those conversations and support.
Yeah, I think that's a really, really good point. Thank you so much. Okay, thank you, everyone. Oh, yeah, Richard.
Hi. Yeah, so we did a lot of work on this previously, and we did find that changing and ensuring that, firstly, the MDT coordinator has enough time to actually transcribe what the outcome is super important. And equally, stopping for the abbreviations, the spellings, because sometimes there's so much information, and if you're whizzing through, they're not even finished the last outcome and someone's talking about the next patient. So time for the coordinator, number one. Number two, actually naming, for us, it's naming the consultant is so important to give them that ownership, because often our cancer nurses are the ones that then perhaps action part of it. But if it's scans and proceeding clinic, it has to be a named consultant to do it. Then we did another piece of work which was interesting, because we actually saw the timing on how consultants action is very different. And we had some people action on the day, and we always thought actually we needed trainees to be in the back. So if there's a scan to be done, can they do it then and there, or can a CNS have extra time to do some of the jobs then and there? Because actually there was a delay of up to sometimes 2 weeks for ordering scans, requesting an oncology referral, all of this kind of stuff from date of the MDT. And it's a really good pathway review technique, just see how quickly people action the outcomes, because it does make a difference. We're still working on that because it's very difficult, because if consultants are away, who's going to cover that consultant's patient? We do have a system where it's the on-call consultant, but it doesn't always work that way. So yes, I think the outcome is really important, and I'm very grateful that it was mentioned about data protection, because we definitely don't do that. So that's something I'm going to definitely take away to our group and have a think about how we deal with that. But yeah, naming the consultant and working out how long is it going to take for people to action. I think that's really important from our side anyway.
Thank you for sharing, Richard.
The outcomes for our patients, Richard, are only shared with MDT members. So that's the governance that covers that. So I don't think we have any concerns. They're not being shared across the region willy-nilly. They're purely with people who are MDT members, so therefore could have taken part in that discussion if they were present in the MDT.
Thank you, Anne. Okay, we will move on to room 3, which is the room I was in, and Ambika was going to summarise our discussion, but unfortunately they've just messaged me. They've had an urgent issue in clinic they need to go and drop off to attend to. So I will summarise our discussion, but I'll invite Nancy and Daniel to kind of chip in if I miss anything, or that they want to share any of their thoughts. So we were discussing time, which is obviously short for everybody, and specifically how specialist MDT discussions can be made more efficient to ensure that there is enough time to discuss the patients that are referred through to them. And everyone described issues with this in having too many patients going through the MDT, I think Ambika said it at King's, they have 2 MDTs a week, and it's still not enough time to deal with the volume of patients coming through. So we talked about possible solutions about actually how can the SMDT become more efficient. And actually the solutions were very similar to how you would approach making a local MDT more efficient. And we centered our discussion specifically on triage processes. So triaging referrals that come from other MDTs into the specialist MDT to ensure they're appropriate, to ensure that all information is included, so that, you know, the right patients are being discussed on MDT. So we had a few thoughts about actually who needed to be part of that triage process. So there were, you know, opinions about actually how it has to be possibly a consultant leading that process to ensure it's clinical, it's clinically led and safe, how the coordinator needs to be involved, how a CNS needs to be involved, particularly from a patient voice perspective, and potentially the involvement of other specialties in that conversation to triage effectively. But actually that came up with some issues and some barriers to that solution, because actually in terms of job planning, and actually those people having time to do that triage. So then we discussed solutions to that barrier, and we discussed actually having some guidance around triage, so written guidance, possibly contributed to by different specialties on actually what patients need to be discussed at specialist MDT, what information is required from each specialty, and actually how that triage can be done. Also upskilling and training more junior clinicians such as registrars to be able to do that triage in place of consultants. And I think I've run out of thoughts actually. So yeah, ours centered around triage. Just wondered if Nancy or Daniel want to correct me on any points or contribute anything else to my summary. No, I think I got it. So yeah, so it's the idea of actually making the specialist MDT more efficient to give everyone that time, but actually it's no different to making a normal MDT more efficient, so that the same kind of principles apply. Okay, we will move on to room 4. Who's representing room 4?
I'm going to feedback on room 4.
Go for it.
So we had some interesting conversations about technology. And it wasn't as I was expecting it to be, which was good. So there's sort of 3 buckets, I guess. One is people using the technology that currently exists incorrectly or not effectively. So examples of imaging and pathology scans and samples not being shared effectively or in a timely way, leading to delays. There was also the use of how technology is being used, but it's not necessarily helping. So we had two clinicians from the same organisation on the call, and they're in an NDT where it's quite multi-site. They have specialists from other organisations dining as well. So people are obviously it's a team-based, largely a teams-based NDT, although there is a physical room that some people do attend. And actually what they're finding is they got people dialing on phones, tablets, and they can't access or they can't see stuff brilliantly, and therefore that's potentially limiting discussions. Also the quality of the technology that's in existence anyway with Teams, etc., isn't maybe the standard that certainly radiology would like to be able to share images with the clarity needed for people to be able to see what's going on. So yeah, interesting. Yeah, it's an interesting thing around is it better to have someone in the MDT or not on a phone or not there at all? And I think you see that big argument, but actually is there a sort of standards? We'll come on to what some of the solutions might be in a minute. And then I think there was just like, are we utilising technology effectively, and is there more that can be done with technology to help support MDTs? That's, I guess, the more what I was expecting a lot of the conversation to be happening. So around that, so we I think, you know, simple things around having clear, well, as other people have talked about, you know, clear process for referrals and expectations is key. Like having some sort of standard process is right. We talked about having a sort of standard approach for how technology is used, so that, you know, what are the expectations of the people? Like, is it a reasonable thing that a clinician is attending an MDT on their phone? You know, not be able to put their camera on. Is that acceptable? And, you know, it may be, it may not be, but having that sort of standard and set down about how people should interact with the MDT, I think we talked about. We did talk again about utilisation of pre-meets to actually help, you know, making sure that the technology has been used and we've got things able to be shared, because people were being bumped off MDTs because stuff wasn't available. And then we talked more about how alliances, I guess, could help with some of the technology. So I think we talked about, you know, funding is obviously a big problem when it comes to technology, but alliances are sort of well placed to support that, maybe trial things, and then ideally share, you know, spreading that technology across a system so everybody is utilising the same thing. It's quite interesting to hear what Richard was saying around the technology in terms of patients being referred. We know that that's a sort of system-wide approach, and that I think has got a lot of benefits, because we're also hearing, you know, everybody's got technology but doesn't all interlink with each other and doesn't necessarily streamline stuff for people when patients are moving between organisations. So those are sort of big ticket things, but it was interesting that actually a lot of it came down to, you know, actually getting people into sort of face-to-face meetings to agree some stuff and principles up front and how we utilise these things. So it was different to what I was expecting, but also quite enlightening. So I don't know, Paul and Neera have anything else they want to add, but if not, I'll hand back to you, Robin.
Yeah, I think that was a great summary. And we did also think about the outcomes and how they were projected and seen, and AI as well, but we kind of ran out a bit of time by then.
Yeah, that's very true. We just got on to potentially how AI could support, certainly without coming, which, you know, those who use Copilot or whatever to summarize Teams calls it is remarkably accurate. So there's definitely, you know, that feels like, if it's not already in places, it feels like something that's going to be coming along very soon, and hopefully will be massively useful, because as we just heard from all the stuff around abbreviations and that kind of stuff, like hopefully that will is it maybe a potential way of resolving some of that. So yeah.
Thanks so much, Matt, and thanks, Paul. Yeah, I think I was involved in a conversation the other day about a Copilot pilot for MDT outcomes. I'm currently chasing down who is doing that pilot and what the outcomes are, so I can share with people. So, you know, when I get that information, I will try and share it as widely as possible, because I think it's really interesting. Thank you so much. I think we've come basically to the end of time we have for this section, but thank you again so much for everyone for getting involved in those conversations and participating, and for all those people who fed back to us. I know it's a bit daunting sometimes verbally feeding back to a large group, but thank you so much for doing that. And I will pass back to Matt. Thanks, Robin. And thanks, Robin. Yeah, I mean, some really interesting stuff that came out there. You know, as with all these sort of improvement things, there's always some simple things that can make a difference, as well as, you know, some big things that need a sort of larger approach. But, you know, it was good to hear about, you know, that we had people that have resolved some of these challenges or are in the process of doing so. And I think, again, I mean, leading into this session, we're like, oh, it's 20 minutes too long for a conversation. Actually, it turns out we probably should have given everybody 40 minutes to talk about it. So thank you very much for all your interactions. I hope you were able to take some stuff away. We're going to just finish with a final Menti, just to capture hopefully some next steps. I guess the point of these sessions, and you know, it's helpful to have a conversation and sometimes an outlet to vent about some of the challenges that we all face. But I think if we can, what we're
the purpose, I guess, of these programs is to say, right, is there stuff that people can take away and do something with? So, Christoph, if you want to just push us on to the. So it'd be really interesting for people just to sort of think about, is there something from today that you can take it back to MDT and implement, or is there an idea, potentially maybe an idea that you want to explore further with your MDT? Because I think everything we've talked about is stuff that comes up whenever we talk to anybody around MDTs. It's the challenge of communication, it's a challenge of standardization, it's a challenge of using a technology effectively, and it'd be really great if, you know, from this program that, you know, you're able to do something around this, so that when we run this session next year, one of you guys is at the front saying, right, this is what we did. And as I say, you know, often it is simple things, and I think it's been really interesting today to hear about the importance of relationships. And even Richard, where you were just talking about how you've used that system for 2 patients, just the fact that you're able to easily communicate back and forth with people around a patient, I'm sure has made things even easier, even though you can see initially people are like, oh god, this is another system I have to use, but actually it's hopefully saved you time elsewhere. So that's really powerful stuff. So yeah, I think the first comment there is absolutely bang on. You know, talking to others in the same situation really helps. It helps you understand that you're not alone, but also what other people are thinking about, and that there is, I think, there can be energy when you talk to other people, like, right, actually we got the potential to resolve some things. Yeah, utilisation of alliances, they are there to support this stuff, and they are really keen to do it. The patient voice section on referral form, I think that is a brilliant idea, and I think if you do that, please can you let Robin and others know, because they would, I'm sure, love to be sharing that nationally. Yeah, referral communication, yeah, preparation, clear, questioning, exactly. Yeah, I think the ratio, we as Robin alluded to, we were discussing, we met with the clinician earlier on this week who unfortunately couldn't attend today, and that was their message. And it was really interesting hearing how he had taken over a quite challenged MDT, and actually when he got down to all of the stuff that he'd done to make it better, it largely came down to making everybody feel like they were part of the MDT and part of a team, and building relationships and talking to people and giving them airtime to. It wasn't just him in the sense of saying, well, this isn't working for me, so everybody else needs to bend to my will. It was trying to sort of co-design. We want to be, you know, use buzzwords for it, but that was quite interesting. Yeah, looking at referral form, pre-MDT leads for clinicians, I think it's a really good idea. So brilliant, thank you. So, as I say, this is a really challenging area that almost everybody faces, and so, yeah, really keen to hear about anything you do that improves that. But I do think, yeah, not you speaking to things like alliances, like that's their one of their major things is trying to help this sort of system working, and so I'm sure they'd be really keen to help test and improve things and provide some support to get things off the ground, because if you can, I think the final thing I'd say before we move on to the end is, like, again, I think Rich, you alluded to this, there's a lot of delay around this bit. Like it takes time for, at the moment it's a you know, we see it when you just look at patient pathways, that many patients that move between organizations, they are inherently more delayed than those that have a whole pathway in one organization. And we've found when we've done work with people that looking at those administrative processes, it can be quite remarkable about how impactful they can be, especially if you're in a system where it's been, you had a really like delayed pathway for a bit, and as you start making improvements, you find that actually people, you know, the administrative stuff is then suddenly becoming much more of a big ticket item. So that is sort of us for today. We've got another session actually next week, and I'll just do a bit of I'll move on to that in a minute, Chris. So there's another session next week, so it's a bit quick succession because we delayed this one because of the industrial action. So we've got a session 4 next week, so hopefully we'll see you there. We've also put this up, so we the team that I work for in my day-to-day role, we have been running these things called mass on open online courses, or as we call them, MOOCs, which is a great acronym. They are sort of supported and facilitated sort of learning things. They're made for sort of operational management teams, MDT coordinators, that kind of role. Although we're always great to have clinicians on them, but it is a I think it runs for 8 weeks, but it's a five module supported learning course where you get a module released each week. It takes about an hour to go through the module. You get to listen to people like myself talk over presentations, and then there's sort of supported learning, and then there's not group, there's sort of discussion forums available. We normally get around about 1,000-ish people doing each one across the country, so it's a good opportunity to get, for especially if you've got people in your teams that are new to sort of the cancer management world, or just understanding how sort of cancer runs. So there's stuff around rules, and there's stuff around governance, why PTL meetings are important, why MDT meetings are important, and use of data and stuff like that. So they're generally well received. It's obviously free. As I say, you get a module a week for 5 weeks, but we have, I think it's a 7 or 8 week total process, so that you've got time to do it when it fits in. As I say, it's about 5-ish hours, 5-6 hours of actual doing stuff. But they've been really well received. So if you've got teams that are interested, please do circulate that. So if we got any, I think let's go through hand over. There we go. Next week, this is what we're doing, session 4, MDT preparation. So we've got a section on that next week, and then obviously you can see the dates for our further ones. So I think that's it. Is there a final slide, Crystal, or is it just goodbye? Let's have a look.
I think that's it in terms of slides.
That's it. Perfect. So thank you very much for your time today. We've got 9 minutes to do your emails, so thank you for interacting and being present, and having some fantastic discussions. And yeah, we'll have to maybe amend this for next year. Hopefully we'll have some people to show some good work, but if not, we'll have to give them more time to some of these discussions, because it clearly was fruitful today. So yeah, thank you for your participation, and hopefully see you next Tuesday.
Thanks everyone.
Thanks all.
Thank you.
Bye.
Thank you.